Good to see everyone entering the room. My name's Helen McLean, and I'm from Heart Support Australia and also representing ACRA WA. The other people within our collaboration are Rural Health West and WA Country Health Service and the Rheumatic Heart Disease Registry. So we welcome you to today's webinar. I'll start by acknowledging the traditional owners of the lands where we meet. I pay my respect to the Whadjuk people of the proud Noongar Nation, whose land I am on. I acknowledge and recognise the importance of self-determination for Aboriginal people, and that we must stand beside Aboriginal people to restore pride in the past and the present so we can together inform the future. I acknowledge Aboriginal people's courage, resilience, and their gentle spirits. So welcome today. It's great to see people from other states, but mostly from WA and represented from the south to the very far north and many, many communities in between. You have all been put on mute. You can type questions in the chat during this session, and you will be able to come off mute and ask questions at the end. There will also be a very quick 30-second evaluation at the end, which we wish you all to complete, as this informs what we can bring to you for the rest of the year. So today it gives me great privilege to introduce Dr. Imran Shiekh, and I welcome him and thank him very much for taking time out of his busy day. Imran is an interventional cardiologist with a special interest in chest pain syndromes, acute coronary syndromes, microvascular artery disease, heart failure, and of course, spontaneous coronary artery dissection, which is what Imran will speak to today. So I'll pass to you now, Imran, and thank you very much.
Thanks, Helen, for a nice introduction. Thanks to Heart Support Australia and Rural Health West for giving me opportunity to talk about SCAD today. And I want to thank everyone who is on the meeting to take time to join the talk today. So I will just start sharing my screen in a sec. Helen, can you see my screen?
Not just yet. It was fine before, and that's all good because people are still coming in from their lunch break. So just ensure it will come.
Right.
Screen share. The little share content. Yeah. Coming.
Right.
We had it before.
Yeah, let me just cancel it and try again.
Yep. Okay. If not, I can have a go.
For some reason, it's not letting me share. Do I need some permission from someone?
Oh, that would be Taylor. Taylor?
It should be letting you. So when you click the little share button next to the red leave thing, what is it saying?
So when I click the button, so there's an option of sharing windows or entire screen. So I tried both. entire screen as well as window. So I got a share button which is kind of highlighted in blue, but when I click it, it doesn't do anything.
Okay, so if you click the share button and then if you click screen, what does that say?
So nothing. So when I click the share, it so previously it kind of shared the screen, but it doesn't let me share the screen now.
Is that because we pressed hide earlier? Remember no, it wouldn't be to do with that. I've sent Imran's PowerPoint to yourself, or I can open it and you can tell me when to move on.
Yeah, that's fine if you can open the PowerPoint.
Yep. I'll just first.
Try. I've just stopped spotlighting you, Imran. Maybe that might have something to do with it. If you try clicking share again, I'm not sure, but just
No.
No.
No. Okay, but Helen, if you can share the PDF file, then I will go through it.
Oh. I'm just going to stop for a minute. And hang on. Desktop. Just have to move my screen. That's okay. I popped it on my desktop. Hang on 2 seconds and I'll be with you.
So what I want to try is I will just quickly leave and rejoin and see if that works.
Yeah.
It's very odd considering he was sharing before and he hasn't left.
Right. So apologies all. It flows much better if Dr. Sheikh can share his screen. However, if not, I've got mine ready now. Great. I'm ready as well, Imran, if yours doesn't work.
Sure, no, it's not working. If you don't mind sharing the screen.
Oh, good. Hey, can everybody see that now?
Yeah.
Yeah, I can see that. Sorry about that. So I'm going to talk about spontaneous coronary artery dissection. Next slide, please. So I've got no conflicts, no disclosures. Next slide, please. So what is SCAD? SCAD is a non-traumatic and non-iatrogenic separation of coronary arterial wall by an intramural hemorrhage, which creates a false lumen. There is separation between the layers of the arterial wall, a separation between intima and media, or between media and adventitia. Next slide, please. So I'm going to illustrate that in the following diagrams. The diagram A is a normal arterial structure. It has got 3 layers: intima, media, and adventitia. And the image B, this is a case of an intramural hemorrhage. There is a hematoma formation between media and adventitia because of the bleeding from the small blood vessels, vasa vasorum, within the wall of the artery. As the bleeding increases, the hematoma size increases, it compresses the intima media and causes occlusion of a lumen to a varying degree, which causes ischemia and infarction. As the pressure from the hemorrhage increases, it can cause tears in intima and cause dissection. So that's the proposed mechanism for spontaneous coronary artery dissection. However, there's a second mechanism as well, which is the initial event may be a tear in the intima, and then the blood from the lumen entering through the tear into the wall of the artery and causing a hematoma. So there are these 2 theories, which are 2 possible mechanisms of the SCAD. Next slide, please. From the autopsy studies of patients who had SCAD, we have noted that in the segment of coronary arteries in which they had SCAD, on autopsy, we have seen a hematoma formation and varying degrees of inflammatory infiltrate. We don't typically see atherosclerotic plaques in those areas. Next slide, please. So we believe the first reported case of SCAD was in 1931. This was a 42-year-old lady who had fish and chips at a local shop, and following that had intense nausea, vomiting, and retching throughout night, and in the morning had a cardiac arrest and passed away. The autopsy in her case showed that there was a dissection of the right coronary artery, there was no plaque, and there was also associated dissection of aorta, suggesting that there may have been an underlying connective tissue disease causing dissection in these two arterial beds. Next slide, please. Previously, we thought that SCAD is extremely rare and prognosis is very poor. However, in the last 10, 12 years, as more data has been collected, registries have been established, we now know that it's not as rare as we thought. It accounts for approximately 1 to 4% of acute coronary syndrome presentations. And we believe previously a lot of cases were misdiagnosed or underdiagnosed. Majority of the cases, more than 90%, are females. Males constitute less than 10%. A median age is 40 to 60 years. However, we are seeing SCAD in patients younger than 40 as well as above 60 years now. It's the #1 cause of acute myocardial infarction in women less than 40 years of age. Next slide, please. LAD and its branches are most commonly affected in 45 to 60% of cases. Left main coronary artery is involved in around 4% of cases. Around 10 to 20% of cases have multi-vessel SCAD involving different coronary vessels or sometimes extra coronary vessels as well. In majority of the cases, mid and the distal portions of coronary arteries are affected with SCAD, except in pregnancy-associated SCAD, where predominantly proximal segment of the blood vessels, including left main coronary arteries, are involved, and that leads to a poor prognosis of pregnancy-associated SCAD as compared to the SCAD in patients who are not pregnant. Next slide, please. In SCAD, we talk about a susceptible patient and a trigger. There has to be an inherent susceptibility of a patient to have dissection, and then there's a triggering event. In terms of susceptibility, we know various connective tissue diseases predisposed to SCAD, the most common being fibromuscular dysplasia. I will talk about it in detail in later slides, but it's a connective tissue disease affecting medium-sized arteries, weakening the walls of the arteries, predisposing them to tears. So similar kind of mechanism, but a different gene and different mechanism is involved in other connective tissue diseases like Marfan syndrome, Ehlers-Danlos syndrome, and inflammatory arteriopathies. There are some case reports of eosinophilic arteritis predisposing SCAD. There also has to be a genetic susceptibility. We don't have a very clear understanding of the genetic or the genes involved, but certain genetic loci have been identified which increase the susceptibility of a person to have SCAD. And most of these genes and gene loci are for the proteins and the components of extracellular matrix. And the mutations in them change the extracellular matrix and may cause weakening of the arterial wall and predisposing for SCAD. SCAD is quite common in females, and there is a certain portion of the patients are pregnant at the time of SCAD, so it points to the female hormonal influence, especially estrogen, which may be involved in SCAD. We know estrogen can cause vascular remodeling and change extracellular metalloproteinases, and that mechanism may lead them to susceptible for SCAD. Next slide, please. Sorry, next. With respect to the triggering event, in males, we note that SCAD event is often preceded by an intense exercise, especially in extremes of temperature, too hot, too cold with intense exercise. very common to find that event in males before the SCAD. In females, we find an intense emotional stress, intense Valsalva manner, severe vomiting, retching can trigger the event. There are case reports of patients having SCAD after use of recreational drugs, mostly males. Next slide, please. The presentation of patients is similar to acute coronary syndrome. These cohort of patients have very minimal cardiovascular risk factors like diabetes, dyslipidemia, hypertension. Most of them may have one or at the most two risk factors, predominantly hypertension. Majority of the cases present with chest pain radiating to arm, neck, associated with diaphoresis, nausea, shortness of breath. 25 to 50% of cases present with ST elevation myocardial infarction. 4 to 14%, depending upon which case series we look at, present with ventricular arrhythmias and cardiac arrest. And a recurrence rate is 2 to 3% per year. If we look at the studies and the data, which dates back more than 10 years, the recurrence rate has been put high at around 20-30%. However, the recent studies have shown that the recurrence rate is much lower than previously thought. Next. Right, so I'll go through the different mechanism of myocardial infarction in patients with plaque rupture versus SCAD. So on the top, it's a type 1 acute coronary syndrome, which is a plaque rupture. If you look at the picture on the top, you can see there is a optical coherent stromographic picture of an artery, and we can see where Helen has pointed the arrow. There is a plaque. You can see plaque from 4 o'clock to 6 o'clock. And in the picture next to it, there's a rupture of the plaque. The cap overlying the plaque has ruptured. The platelets has come in contact with plaque, and it has activated platelets and caused a thrombosis, which blocks the blood vessel to varying degrees, causing myocardial infarction. In ACS patients, we aim for sealing the plaque, putting the stent, opposing it fully to the wall, and restoring the normal caliber of the artery. In the second picture down on the right, which is SCAD, so there is no plaque. We can see there are two lumens. The one where the arrow is pointing is a true lumen, and the one next to it is a false lumen. And there is a intima separating the true and false lumen, and the hematoma where the arrow is pointing, that's a hematoma compressing the true lumen. The picture next to it, you can see a circumferential hematoma compressing the lumen. We don't see any plaque in that picture. In SCAD, the hematoma resorbs on its own in 4 to 8 weeks, and the artery heals itself, and artery caliber comes back to normal. So we aim for conservative management of these patients wherever possible. Next slide, please. Sorry, next slide. It's very important to diagnose SCAD early on because the investigations, initial management and long-term management of SCAD is very different to acute coronary syndrome patients. Invasive coronary angiogram is a gold standard investigation for diagnosing SCAD. There are different patterns, angiographic patterns, which we see in SCAD. In some cases where angiogram is ambiguous, we use intracoronary imaging like intravascular ultrasound or OCT. CTCA is not recommended as an initial investigation for SCAD because the spatial and temporal resolution of CT is very low as compared to invasive angiography. And SCAD mostly affects mid and distal vessels, which are small caliber and relatively difficult to visualize on a CTCA. However, we can use CTCA as a follow-up investigation, which I will talk about a bit later. Next slide, please. So over the previous 10-15 years, we have missed a lot of cases of SCAD. One, due to low index of suspicion when we see young males or females without significant cardiovascular risk factors, often their chest pain and sometimes even trough rise is kind of ignored. The overall impression was like they're young, they don't have risk factors, they can't have myocardial infarction, and some cases have been missed because of that. And those who came to the cath lab, some of the cases have been diagnosed as stenosis, some as coronary vasospasm, and some diagnosed as normal coronaries. Because at that time, 10, 15 years back, there wasn't a clear criteria for different angiographic appearance of the SCAD. As with more research, different angiographic patterns have become more apparent. We are diagnosing SCAD more frequently now. Next slide, please. So Vancouver Group in 2017 came up with the angiographic classification of the SCAD. They came up with 3 different types of angiographic patterns, which we see in SCAD. Now a 4th has been added recently. Next slide, please. The first picture on the top is a type 1, where there is clear dissection, 2 lumens, and a contrast staining. This is a typical classic textbook definition of dissection, and it's very difficult to miss on an angiogram. It's very apparent. The next picture, B, you can see where the 2 arrows are pointing. On the top, there's an arrow. Prior to that, the vessel caliber is normal, and then there is sudden narrowing, and the vessel caliber is again back to normal after the second arrow. So in this segment, there is intramural hematoma concentric, which is compressing the lumen and narrowing it. In this case, to a severe kind of a degree. If you see picture C, we again see an example of a change in caliber of the blood vessel because of the intramural hematoma. But the difference is in C, we don't see return of normal caliber, which means the intramural hematoma and dissection extends right up to the distal segment of the vessel. And if we go to picture, if you have a look at the picture D, this is type C SCAD, and this is very difficult to diagnose on angiogram because it looks very similar to an atherosclerotic plaque. There is a focal or tubular narrowing, and on angiogram, it's difficult to say whether this narrowing is because of a intramural hematoma or is it because of a plaque. In these cases, we use the intravascular or intracoronary imaging like intravascular ultrasound and OCT, which helps us identifying whether the stenosis is because of the plaque or is it because of a hematoma. Next slide, please. Next slide.
Oh.
Yeah. Right. So these 2 pictures, the golden one is an optical coherence tomographic pictures taken from inside the lumen of a coronary vessel, and the one next to it is intravascular ultrasound. In the picture B, we see that there is a normal arterial wall between 2 to 4 o'clock, and after that, a hematoma is compressing the true lumen from around 4 o'clock to 1 o'clock. And if we see picture B below it, at a lower level, there is more compression from hematoma, and the lumen where the circle is, that lumen is completely compressed. So here we can clearly see there is no plaque, there is a hematoma which is compressing the true lumen. And by ultrasound and IVUS, in these cases, ambiguous cases, we can differentiate between acute coronary syndrome and SCAD. However, the challenge is when sorry. So the challenge is when we are putting wires and additional catheters through arteries which are dissected, there's a risk that the catheters and wires can go into the false lumen and can extend the dissection. However, in ambiguous cases, sometimes it's important to kind of make a correct diagnosis. Next case, please. This is another example. This is an angiogram of LED, and at the site where there are multiple arrows, we have taken an optical coherence tomographic picture, and it is clearly shown there is true lumen, which is where TL is written, and there's a false lumen, which is compressing the true lumen. And we don't see any plaque there. Plaque has a very different appearance on OCT. So in this case, we can clearly say that this angiographic appearance on myocardial infarction is because of SCAD and not from ACS. Next slide, please. Oh, yeah, sorry. So we spoke about predisposing conditions, and approximately 60 to 70% of patients who have SCAD also have associated fibromuscular dysplasia. It's a connective tissue disease, a non-atherosclerotic, there's no plaque involved, non-inflammatory disease of arterial walls, predominantly affects females and with very minimal cardiovascular risk factors. Now, fibromuscular dysplasia is broadly divided into two groups. One is focal, other is multifocal. In multifocal, there are multiple segments of an artery involved with stenosis followed by aneurysms and alternating stenosis and aneurysms, giving a typical string of bead appearance. It affects the small and medium-sized arteries, most common being renal artery, where it can cause same stenosis, aneurysms, resulting in hypertension in the young. At times, we have to do angioplasty of these stenotic lesions to restore the blood flow to the kidneys and treat hypertension. It can also cause aneurysms in renal arteries, which we do surveillance of with ultrasounds, and if the size increases significantly, then that will need to be surgically treated as well. It can affect intracranial vessels, causing tinnitus, migraine, headaches, stroke, and TIA. Iliac arteries are involved as well. Coronary arteries, it's associated with SCAD. We see a lot of patients with FMD have tortuous coronary arteries. When we compare angiograms of patients without FMD to angiogram of patients, angiogram of patients with and without SCAD, we find that the incidence of tortuosity is quite high, around 30% in patients who have FMD, whereas it's around 10% in patients who don't have FMD, which leads us to think that maybe coronary tortuosity is a manifestation of fibromuscular dysplasia in coronaries. However, it's not widely accepted. And for the same reason, for all SCAD patients, we screen them from head to pelvis for FMD changes. We either use a CT angiogram head to pelvis to look for fibromuscular dysplastic changes in different arterial beds. In cases where we are worried about the radiation, we do MR angiogram head to neck to reduce the radiation dose to head and neck and thyroid, and do CT angiogram from chest to pelvis. Next slide, please. Depending upon the various case series and registry data, that FMD has varied from 40 to 80% in different cohorts of SCAD patients. Next slide, please. These are pictures of fibromuscular dysplastic changes. The one on where the arrow is a fibromuscular dysplastic changes in the renal artery where there is beaded appearance. This is because of the stenosis due to fibrotic collagen bands followed by dilation. So there is a collagen deposition at the site of stenosis, and then there is disruption of elastic lamina next to it. So one side gives stenosis, another side will give you a dilation. We see similar but subtle changes in the iliac arteries on the lower images. Next slide, please. Because of preponderance in females and its association with pregnancy, female sex hormones, especially estrogen, has been implicated. Estrogen can cause vascular remodeling and change in extracellular matrix, which may predispose to SCAD. Overall incidence of SCAD is still very low in pregnancy. In this Canadian studies, where there were 4.4 million pregnancies they screened, there were approximately 1.8 SCAD cases per 100,000 pregnancies. And most of the SCAD occurs in the third trimester and early postpartum. Next slide, please. Pregnancy-associated SCAD has got more severe presentation. The prognosis is poor because it affects predominantly left main and prox LAD. A majority of the patients present with STEMI, cardiogenic shock, cardiac arrest. Overall mortality is higher than SCAD patients who are not pregnant. They end up having more LV dysfunction. Their mean ejection fraction at 30 days and 6 months post-discharge is lower than other SCAD patients. Next slide, please. For management, all SCAD patients, less is more. We prefer conservative management in most cases. One reason being that more than 95% of cases, the artery heals itself in 6 to 8 weeks and restores the luminal diameter. And number 2 is that intervention is associated with high risk of complications and failure rates in SCAD as compared to the ACS patients. We reserve acute coronary intervention stents only in cases who have ongoing ST elevation, ischemia, or hemodynamic compromise, cardiogenic shock, refractory arrhythmias, or where there's left main involvement and a lot of myocardium is at risk. Next slide. So the challenges which we face during intervention is because the artery has got true and false lumen. When we pass a wire, we pass wire under a 2D angiographic guidance. It's impossible to determine from that picture whether the wire is going through true lumen or false lumen. And sometimes it can partly be in the true lumen and partly in false lumen. And then when we pass tubes, catheters, and if the wire is in false lumen, that will obviously cause extension of dissection and more obstruction of the lumen and compromise of blood flow to the myocardium, so making the dissection and ischemia worse. The second problem which we face is when we put stent in, we try to deploy stent so it's well opposed to the wall of the artery. In this case, because there's an intramural hematoma, when we deploy the stent, the hematoma extends proximal and distal. So there's an extension of dissection into a normal segment, necessitating more stents proximally and distally. Next slide, please. So at long term, there is higher risk of stent thrombosis if we deploy stents in SCAD patients. Now, stent thrombosis occurs when there is exposed metal struts. They come in contact with platelets, there's platelet activation and thrombus formation, and varying degrees of thrombus formation can cause varying degrees of obstruction to the blood flow and myocardial infarction. So that's the mechanism for stent thrombosis. The risk of stent thrombosis in ACS is very low with current generation stents, approximately 1 to 1.5%. In SCAD, it's high. The reason being when we deploy stents, there's an intramural hematoma, and even if we oppose the stents well against the wall, there is still a residual hematoma which resorbs in 6 to 8 weeks, making the wall to move outwards and leaving some parts of stents in the lumen, which then it's quite difficult for them to have endothelization, which protects from stent thrombosis for the stents which are opposed to the wall. So at some point of time, we have to take these patients off dual antiplatelet therapy, especially young females, if they want to have families and plan pregnancy or for various other reasons. Then at that time, there's a risk of the platelets coming in contact with these hanging metal struts and causing stent thrombosis. If we have a ST elevation MI from a plaque rupture, the mortality rate is currently low. However, if we have ST elevation MI because of the stent thrombosis, the mortality rate is very high, 30 to 40%. So it's quite a significant event and a significant risk to these young patients. And that's other reason where we are very reluctant to offer upfront intervention unless there's no other choice. Next slide, please. So multiple case series from different international centers have quoted quite high technical failure rate of 30 to 50% with PCI. However, we have come up with various different techniques where we can optimize outcome and reduce the failure risk. One is to use intravascular ultrasound to guide, to check whether the wire is in true lumen and false lumen. And we can also use IVUS to actually guide the wire to the true lumen. In ACS patients, our aim is for perfection. We want all plaque to be sealed, stent well opposed to the wall. In SCAD patients, the main aim is to restore the blood flow because the hematoma and the stenosis will resolve itself. So in some cases, we do only balloon angioplasty with small, low pressure balloons, just enough to compress the hematoma and open up the lumen so that the blood flow is restored and ischemia is resolved. There have been cases where special cutting balloons have been used. These are balloons who have blades longitudinally across their length, and the pressure imparted at the site of the blades is 5,000 times than the pressure imparted with other balloons. So they help in cutting and decompressing the hematoma. There's always a risk of vessel rupture with these balloons. So we use low profile balloons at low pressure, just enough to decompress the hematoma, restore the blood flow. In cases where we do have to put stents in, we prefer direct stenting without balloon angioplasty so that the hematoma is not extended proximally and distally. And we tend to use stents which are 5 to 10 millimeter longer than the lesion. So we cover 5 millimeter of a normal segment in the proximal and 5 millimeter of normal segment in the distal, so that even if there is some extension of hematoma, it's still within the stented segment and doesn't extend beyond the stented segment. There have been some case reports where interventions have put a short stent in the proximal and distal so that there is no extension, and then dealt with the dissected segment. Next slide, please. In cases where there is a multi-vessel involvement, proximal involvement, ongoing ischemia, or hemodynamic compromise, and PCI is not possible, the other option is coronary artery bypass grafting. It's used in a very small percentage of patients. The graft failure rate is quite high in these patients. The reason being, after 30 days or 60 days, when the artery normalizes in caliber and flow is restored, after that there's a competition of blood flow to myocardium from native versus the graft. And in this competition, native always wins. And over a period of time, the blood flow to the graft slowly reduces and the graft blocks off. But having said that, it might be important only if the patient subsequently develops atherosclerotic disease, and if he needs bypass surgery, we run out of conduits, and the repeat bypass carries higher risk. But on the other hand, if the bypass saves the patient at that point of time, it's better to have a live patient at 6 months with failed grafts but normal coronary flow. Next slide, please. So the main management is a medical therapy. There are no randomized controlled trials done in looking into various medical therapies. There are currently some going, but the results are not available. The role of antiplatelets is a bit ambiguous. The reason being, the initial event we say is bleeding, and when we give antiplatelets, it causes more bleeding and can cause extension of hematoma. The counter argument is that once there is a dissection in the vessel and there is some hematoma formation because of the SCAD, both the dissection and the thrombus is a nidus for more thrombus formation, more platelet aggregation. So we should give some antiplatelet agents. So there are trials currently looking into it, and hopefully we'll have clear answers. So dual antiplatelet therapy is only recommended in patients who have stents. The rest of patients should be only on aspirin. Now, the practice varies. If you look at some of the expert recommendations are up to date. It says aspirin for a year or sometimes lifelong. Whereas there are some other centers in the world where they stop aspirin in some patients after a few months. In patients who have fibromuscular dysplasia affecting intracranial vessels and other vessels, they are at risk of TIAs and CVAs. So an argument can be made that those SCAD patients who have FMD, maybe they should be continued on long-term aspirin. Yeah. And the others will have to do it case by case. Statins, there's no role of statins in SCAD. 7 to 10 years back, there was a study which showed that there's a recurrence rate of SCAD is high in patients taking statins. However, subsequent studies have shown that that's not the case. So if patient needs statins for dyslipidemia or coincidental atherosclerosis, we can prescribe. There is no increased risk of SCAD. However, it doesn't help SCAD as such. The mainstay of treatment is beta blockers. There is an observational study and a meta-analysis which has shown that patients who are on beta blockers, there's a significant reduction in a recurrence rate of SCAD. Again, this is observational meta-analysis data. This is not a randomized control data. The postulated mechanism is that beta blockers reduce force of contraction, they reduce heart rate and blood pressure to a certain extent, which decreases the rate of velocity of flow across the coronary vessel, which reduces the shear strain which the flowing blood imparts tangentially on the walls, and reduces the risk of SCAD. We aim for target resting heart rate of 60 to 70 beats per minute and up-titrate the beta blockers to achieve that. We treat these patients like an aortic dissection patients and try to keep their blood pressure less than 120/80. And if we have to use ACE inhibitors, ARBs, or calcium channel blockers for that, ACE inhibitors and mineralocorticoid receptor antagonists are only indicated if they have concomitant significant LV dysfunction. Anticoagulation is not recommended unless there is a separate indication for anticoagulation. For example, if they have pulmonary embolism or if they have atrial fibrillation with high Chad's-VAS score. There have been some studies which have shown that the outcome of the SCAD patients can be worse if they are on anticoagulation. Again, registry data not proved in randomized controlled trials. Next slide, please. Next slide. Cardiac rehabilitation is very important in these patients. These patients are very apprehensive to go back to their normal lifestyle, go exercise. They're always worried about having a recurrent SCAD event. We have developed a specific SCAD-related cardiac rehabilitation program in which they get education. They meet with other people who have SCAD, and they have a supervised exercise program where they are supervised when they're doing exercise, and we aim to keep their target heart rate less than 70% of their maximal heart rate and keep the blood pressure less than 130 mmHg, especially in the first 6 to 8 weeks where the artery is healing. The patients get the idea of what activities they can do, what they can avoid. The current recommendation is to recommend to avoid heavy lifting. It's quite a strict criteria currently with weight restriction of 15 to 20 kgs, which is okay for the first 8 weeks, but becomes impractical in a long term. So in a long term, we ask patients that if they are able to lift a certain weight, let's say 20 kgs without Valsalva, without breath holding, without extra effort, they can continue doing it. Similarly, if they are used to running 5 to 10 Ks without being overexerting, they can continue to do it, maybe reduce the pace at which they do it. We ask them to avoid high intensity interval exercises and exercises involving Valsalva manner. Next slide, please. SCAD patients have high incidence of anxiety, depression, and in some post-traumatic stress disorder as compared to the ACS patients without SCAD. So we have a low threshold of referring them to psychologists, psychiatrists, and kind of offering them anti-anxiety or antidepressant medications. Next slide. Yep. Overall prognosis is good. Mortality rate is low. Survival rate is around 92 to 94%. However, the morbidity and MACE rates are high. Often SCAD patients represent with chest pain, which could be for various reasons, often need repeat angiography and sometimes PCI. Around 10 to 20% of patients have recurrent SCAD as well. Overall, in majority of the patients, the LV ejection fraction improves and normalizes in 3 to 6 months. It's very common for SCAD patients to represent with chest pain in the first 30 to 60 days post-SCAD event. There are various reasons for that. One is the recurrent pain from the initial SCAD. Some patients have high degree of anxiety, apprehension, and they come with atypical non-cardiac pains. There are a certain percentage of patients who have extension of dissection or hematoma propagation, proximal or distal, causing more ischemia, which we call as a progression of SCAD. And certain number of patients present with recurrent SCAD, which is a new SCAD at a different site to the original SCAD. When we evaluate these patients in emergency, it's sometimes very difficult to differentiate between these causes. We often guided by their ECG and troponin results. If there are new ECG changes or there's a new rise in troponin, then most likely it's either a progression or a recurrence, and these are the patients we do take for repeat invasive angiography. Often I check CK levels for SCAD patients 1 or 2 days before discharge, and by that time the CK levels have normalized or near normalized. So when they represent, troponin may still be elevated, but if there's a new CK rise, that points to a new infarction. And that way we can sometimes differentiate whether this repeat chest pain, is it progression or recurrence, or is it just anxiety or reminiscent pain from the previous event. Next slide, please. The current recommendation is that any patient who had SCAD should avoid pregnancy. That's the current expert recommendation. However, there are patients who have decided to go ahead with pregnancy, and there have been variable outcomes depending upon which case series we look at. If someone chooses to be pregnant, there should be an open discussion between the patient, partner, and the cardiologist, obstetrician, neonatologist, obstetric anesthesiologist should be involved in the decision making. The planning has to be quite kind of comprehensive. We have to try to arrange their delivery in a center where there is interventional facilities. And we aim for a vaginal delivery under epidural anesthesia, and aim is to minimize the maternal effort during delivery. So we talked about the extra cardiac screening for FMD and other associated conditions, and it's CT and MRI scan, which we typically do. Next slide, please. So in summary, we should have a high index of suspicion for SCAD, especially in young females without cardiovascular risk factors. If they present with ACS type picture, we should consider it as a SCAD unless proven otherwise. Coronary angiography is a gold standard investigation for diagnosing SCAD. We prefer conservative management. Number 3, role of antiplatelets is ambiguous, and currently randomized controlled trials are going on, which will kind of clear that question. Beta blockers are mainstay of treatment. There's no role of statins. When they present with a SCAD event, we keep them in hospital for a bit longer than the ACS patients because of the risk of progression of SCAD. And typically, we keep them under cardiac monitoring for 3 to 5 days. If they have recurrent pain, then that period can be extended. Cardiac rehabilitation is very important in gaining their confidence. It improves their quality of life, their mood, and has shown to improve outcomes. Again, low threshold of treating anxiety and depression. All SCAD patients have to be screened for fibromuscular dysplasia and other connective tissue diseases. CTCA can be used as a follow-up in selected cases. If there are patients with a proximal hematoma, which we have conservatively managed, and we want to see after 6 to 8 weeks whether it's resolved completely or not, especially if they're having some symptoms. At that time, instead of going for an invasive angiogram, which carries high risk, we can opt for a CTCA. CTCA is reasonable to do if the caliber of the vessel where SCAD event has occurred is large, and especially the proximal vessels. Next slide, I think that's it. So we are currently participating in Australia and New Zealand SCAD registry. We are both taking prospective patients as well as retrospective patients. And if you have any SCAD patients who had SCAD anytime in the past, we're happy to kind of enroll them in the registry. In future, we'll have different trials with different medications for SCAD patients. If they're enrolled in SCAD registry and consent to it, it's easy to kind of contact them and kind of offer them those therapies. Next. Thanks. Any questions?
I'll stop sharing, and yeah. So just having a look. Questions in the chat. There is interested in why vaginal delivery is recommended. Well, but it was with an epidural so that they wouldn't have to push and have that pressure happening. Is that, and why not an elective cesarean? Louise has asked that.
Right. So when the patients go for general anesthesia, that increases their risk as well. And often in the case series which have been published, most of the patients have gone for a vaginal delivery unless there's other indication for cesarean, and the outcome has been reasonable. In one case series, they had 18 patients who opted for pregnancy, and out of them 16 went for a normal vaginal delivery, and they had no adverse outcomes with the delivery. 2 of them had, but the outcome wasn't kind of mortality.
So I have a question around that. So with the FMD, is it pregnant ladies don't necessarily have FMD? It's about the extra red blood cells causing the problem?
No, we find FMD to be less in pregnant patients who had SCAD. The possible the mechanisms proposed is, and most of the pregnancy SCAD is in multi-gravida patients who had multiple pregnancies, and the exposure, the changes in the hormones during pregnancy and during menopause has been implicated, especially the estrogen. Estrogen has been implicated. It causes vascular remodeling. It causes changes in metalloproteinase and extracellular matrix, so which is kind of presumed to weaken the wall and predispose to the dissection in these cases. And if the patients are on oral contraceptives, and they have SCAD, we advise them either to use the non-hormonal contraceptive measures or go on levonorgestrel, progesterone only contraceptives.
Now, there's another question from Julie. You run a SCAD clinic in Royal Perth, and is it only for Royal Perth patients?
Right. I think we started as a Royal Perth. It's a Royal Perth catchment area, which extends into the country areas as well. So anyone in the RPH catchment area can be referred. Now, with those patients who had SCAD and someone wants to enroll them in our registry, so it will just involve one visit to Royal Perth Hospital where we go through all their angiograms, history, confirm it's SCAD, and enroll them in the registry if they consent to it. And then we don't need any long-term follow-up unless kind of a clinical situation changes. So yes, we will take referrals outside RPH catchment area for SCAD patients. Fiona Stanley Hospital is also enrolling patients in the SCAD registry. So yeah, we are happy to take it outside RPH catchment area.
That's great. Did you want to add anything to that, Julie? I know Julie's at Sir Charles Gardner Hospital.
Yeah, I just wanted to say, how do you enroll them, really? Because we obviously have our fair share of SCAD patients, and they really want to be specific and looked after by an expert in that area. And that's a question they will ask me again and again. Have you got a SCAD specific? And I haven't. So how do I even, because I enroll them in the registry, because that would just be the first step. We do our best here, but it's probably a few gaps.
All right, so we have started a SCAD clinic. It's been running for almost like 3 years now. So we do it in first Friday of each month. So for patients who are at Royal Perth or Royal Perth catchment area or are referred to us, so we book them into the clinic, to the SCAD clinic, and we go through whether the SCAD, we first confirm whether they truly had SCAD. Then we go through whether they had all the investigations and go through their management. And then we do offer them to be enrolled in the SCAD registry. So all they have to do is to consent. Currently with the registry, we put their data in, and we also only need to know their outcome, like a 6-month outcome at present. So that's how we do it. I guess similar clinic can be established at Charles Gardner Hospital as well, or depending upon kind of the interest and the kind of feasibility. But there have been some patients who have been referred to our RPH SCAD clinic from Charles Gardner Hospital, mainly to kind of confirm the diagnosis and make sure that all the investigations are done, and to enroll them in registry. With the CSANs in the SCAD registry, so it's open to all hospitals in Australia. It's run through University of Sydney, and we can enroll Charles Gardner Hospital for that as well. But there has to be a person who takes responsibility of enrolling these patients, seeing these patients in clinic and enrolling them. I think one option is if we have a cardiologist or any physician who has interest in women's health, so they can set up a SCAD clinic like we did at Royal Perth and follow these patients up. For example, if a SCAD patient comes to RPH, even if he doesn't come under my care, they will be booked within 4 weeks into the SCAD clinic just every month. And then I will go through and make sure that everything has been done, enroll them in registry, and follow them up more frequently than in general cardiology clinic, where the wait list can be kind of months to years.
So I might actually just email you offline on this and actually see how we can facilitate a nurse to medical referral, because I think that's where we're lacking, but I'll take this offline. Okay. Thank you very much for that, though. Excellent presentation.
Oh, fantastic presentation. Now, I did have a question. Were you happy to share your slides? I had that earlier. Yeah?
Yes. Yeah,
yeah, your slides were fantastic and all the imagery was really easy to understand. The other part that I've really, the post-traumatic stress, it's more than just anxiety. You actually named it as post-traumatic stress, which I think is the other part that with Julie's patients, etc., is really important, that these people are followed up more than just in a general sense, because that anxiety and the thought of recurrence would really impact them being able to move forward in an emotional sense.
Yeah, I mean, if you look at it, these are patients, they are in their 40s, 50s, or even younger, they're going on with their life, they've kind of, and suddenly they're in hospital with MI, and then they are told, there's no treatment, right? And there is a recurrence rate, it's a life, and if you do a certain level of intense physical activity or weightlifting, you can have recurrent SCAD. So this has a kind of significant emotional kind of a psychological impact on these patients. And most of the patients have anxiety and some degree of depression, but there are patients who have been diagnosed with post-traumatic stress disorder. So I think very important to understand it from their perspective. You have a condition where there is actually no evidence-based treatment at this point, and there is a relatively high recurrence rate, and you have to modify your whole lifestyle. And if then they they still want to have families and stuff, so it's a huge kind of impact.
Huge.
So I think that's why SCAD specific clinics are very important. In general cardiology clinic, it's difficult to give them appointments, and
yeah, that's great. And Prethi has a question. If the patient comes to cardiac rehab for exercise and their systolic blood pressure's over 130, should they be sent to the GP or ED?
If they are within kind of 30 to 60 days of SCAD, and if the baseline blood pressure is already 130, and with exercise it will obviously increase, yes, at that time either a GP or a treating cardiologist should be contacted so that he can either initiate or increase the antihypertensive medication, so that especially in the first kind of healing phase, their blood pressure is systolic blood pressure is less than 120, and so that they be able to do a certain degree of exercise without blood pressure having to go to 160. Yes, I think you should definitely contact one of the physicians so that antihypertensive medications can be initiated. Now, that doesn't mean they have to be on it long term. Subsequently, once kind of a healing has occurred, the blood pressure medication can be reduced.
That leads me to another question. The hypertension was one of the preempting. So hypertension in pregnancy and preeclampsia, are there what's the links there?
So in patients who had pregnancy associated SCAD, there have been seen a higher incidence of preeclampsia, and those who had fertility treatments, there is quite high incidence of those patients having pregnancy associated SCAD. I think fertility treatment is probably related to the kind of a hormonal influence, but yes, there is those who have preeclampsia and fertility treatments prior to pregnancy, they are higher risk of pregnancy-associated SCAD. The incidence, however, is still very low.
Very good. Now, any more questions from the room? You can come off mute. Just give it a minute. Well, if there's no more questions, Imran, that was a fantastic presentation. I learned masses, and I know everyone else in the audience did. And now they can all go out and care for their patients with this extra knowledge and confidence and feel comfortable in what they're doing and who to refer to. So thank you very, very much. That was fantastic.
Thanks, and thanks everyone.
And if I could just ask people to, in the chat, there's a poll. So if you could quickly, it will only